Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interest. If you have a question for the presenter, please hold until the Q&A segment. And if you're attending virtually, please enter your question into the Q&A chat and we'll ask that for you. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Michael Vidal. Dr. Vidal completed his undergraduate studies at SUNY Albany and earned both his medical degree and master's degree from SUNY Upstate University in Syracuse, New York. He is currently a candidate for Pulmonary and Critical Care Medicine Fellowship. His research interests include chronic obstructive pulmonary disease, the impact of climate change on respiratory health, and advanced navigation bronchoscopy. Today, he will be discussing the latest updates to the GOLD report for COPD. Please join me in welcoming Dr. Vidal.
Thank you, Jennifer, and thank you, everybody, for that warm welcome. So here I am, beautiful November day. We're going to be talking today about the GOLD report, specifically the 2025 updates. I'm going to talk to you guys a little bit about what the GOLD report is, kind of the history behind the GOLD report, and how it's impacting and how some of those changes are impacting our practices and our practice changes. So I don't have any disclosures. I do wish I did, but I don't. We've got a couple objectives for today. We've got to list and recognize the new changes to COPD management guidelines, to recall the history of COPD and how it has become the complex pathology that it is today. So we'll start with a case presentation, and I want everybody to keep in mind this case presentation because it's going to influence how we broach the topic of the GOLD report moving forward. So it is October 2024, and we have Miss Emily Fazima. She is a 64-year-old female who presents to clinic for follow-up on her most recent hospitalization. She has a past medical history of tobacco use, moderate to severe COPD, and chronic hypoxic respiratory failure, currently on 3 liters, and she's been hospitalized about 3 times just in the last 2 months, and all of these have been for COPD exacerbations. Her most recent hospitalization lasted approximately 20 days, and after she was hospitalized during this encounter, she was more debilitated than previously and was kind of mostly wheelchair bound coming out of the hospitalization. Her last spirometry test was performed in 2022. It showed an FEV1 of 64%, an FVC of 75%, ratio of 66%, and a TLC of 113%, as well as a DLCO of 47%. It showed moderate airflow obstruction with concomitant air trapping and no bronchodilator response. Her home medications and interventions include a combined maintenance inhaler of ICS, LABA at 100 micrograms, 62.5 micrograms, and 25 micrograms. She's on 2 liters of oxygen at rest and up to 4 liters during any kind of physical exertion. She has these PRN SABAs and SAMAs, and she has nicotine patches at home, but despite that, she continues to smoke about 1/2 pack per day. She does have an at-home ventilator, non-invasive mechanical ventilation that she uses while she's sleeping and as needed during the day when she's feeling kind of wheezy. Her COPD assessment tool is her CAT score is 28, and her Modified Medical Research Council, her dyspnea scale is 4. We're going to go into what all those things mean during this presentation. So I want you to keep all this stuff in mind, and I want you to make a highlight of what you think is important and what you think we can intervene on here. We're going to use this for the basis for explaining our GOLD report updates. She is asking here in our clinic what can be done for her to stop going into the hospital so much, and how best can we control her COPD symptoms. This is a pretty common patient that I see in clinic, and we're going to go over some of the updates and what we can do for her. So utilizing the new the newest 2025 GOLD report, how can we best optimize this patient's care? What are some of the non-pharmacologic instructions that we can provide to this patient to prevent her COPD exacerbations? what are some of those non-pharmacologic and pharmacologic interventions that we could provide to help with her symptoms and her exacerbations, and what additional tests can you order to help guide management. And I want you to think back to our previous case report, because it's going to show up again. So here's kind of what I highlighted. I tried to go through and show you guys what jumped out to me when I'm going through this and what we can intervene on. So it's October, so it's about flu season. We know this, right? She has a past medical history of tobacco use and moderate to severe asthma. She's pretty debilitated and mostly wheelchair bound, which is not good for either her respiratory health or her cardiac health. Her last spirometry was done in 2022. We don't have any kind of updated tests on this. At that time, it was pretty moderate. Her ratio was about 66%. Her FEV1 was 64%. She is on triple therapy, so she's on ICS, she's on LAMAs and LABAs, and she's on 2 liters of oxygen at rest and up to 4 liters during physical exertion, such as like when she's transferring. Her CAT score is 28. You'll see these assessment scores a lot in pulmonology clinics, as well as her dyspnea scale score, which is 4, which is pretty severe. That's actually the most severe that you can get. So these are some of the things that we can act on here in clinic today. So going through all that, what is the GOLD report? The GOLD report, it's a report set out by a lot of different countries. So COPD is now ranked as the 3rd leading cause of death worldwide. 90% of these deaths occur in low or middle income countries. The GOLD report is used to standardize care across all those different countries. It is a 215-page document, which I was able to go through all 215 pages, you're very welcome, that outlines the pathophysiology, diagnosis, prevention, treatment, and advances in COPD management. It consists of national leaders across the world with an interest in promoting COPD management and prevention in their country. This list of countries that are associated with the GOLD report include countries like USA, Argentina, Colombia, France, Germany, Greece, Iceland, Lebanon, Nepal, Pakistan, India, South Africa, Turkey, Vietnam. So it's a pretty extensive list, and all of these, the GOLD 2025 updates actually reflect shifts in evidence, new therapies, and global health priorities. These are headed up by experts from all over these countries, and they all chime in to basically update this on a yearly basis at this point. So kind of the history behind the GOLD report. It is an initiative for chronic obstructive lung disease. It was started in 1998 with a goal to produce recommendations for management of COPD based on new scientific evidence. The first global strategy for the diagnosis, management, and prevention of COPD. This was issued in 2001. Subsequent revisions were done in 2006 and 2011. And specifically the 2017 GOLD report had 5 major updates. So we have both revisions and updates. The most recent revision that was done was actually in 2023 of this year. And that GOLD report that GOLD report was one of the 5th major revisions. We've had several others in the past. The 2025 GOLD report is the 2nd update to the 2023 revised report. These reports, the way that they're collected is they're usually done through PubMed searches. So these, they use the fields of COPD or chronic obstructive pulmonary disease, and clinical trials or meta-analyses in order to sort out these fields. They also use articles in the top 20 medical or respiratory journals or the Cochrane database of systematic reviews. And again, these updates include diagnostic refinements, new biologics, climate impact and awareness, and its effects on COPD. And we're gonna go through that here too. So what is COPD? What is the pathophysiology of COPD? This is probably one of the more interesting aspects that is updated yearly. It's characterized by this poorly reversible airway obstruction. It's confirmed by spirometry, and it includes obstruction of the small airways. Here we see some alveoli. Here we see some alveoli that are being destroyed, and here we see kind of the pathway for how COPD occurs. So we have cigarette smoke and other irritants. This will activate things like alveolar macrophages. These will activate other things such as neutrophil chemotactic factors, interleukin-8, leukotrienes B4. These can activate CD8 cells. And eventually what actually happens is that you have destruction of the protease inhibitors. So you have these proteases that start breaking down the lung and the lung parenchyma going forward. Cigarette smoke and other irritants, these things are the driving force for what activates the macrophages and airway epithelial cells in the respiratory tract. Again, this is kind of the whole pathway that it goes down, leading towards neutrophilic chemotactic factors, interleukin-8. The most common protease inhibitor that you guys know about is probably alpha-1 antitrypsin. So destruction of alpha-1 antitrypsin can actually lead to parenchymal damage in the lung. And this continues and continues on as the more you have these irritants in the lung. The pathophysiologic driver for this is always going to be inflammation, remodeling, emphysema, and gas trapping. And it's important to recognize this disease and some of the players in it, because this exhibits how we can intervene on COPD and what's contributing to its heterogeneity moving forward. So why is COPD so heterogeneous? What are its phenotypes? What are its idiotypes? How did we used to categorize COPD? You guys probably all know about the pink puffers and the blue bloaters. So pink puffers, they tend to have lower body mass index, fewer cardiovascular comorbidities. They tend to have hyperinflation. So you can see things like bullae when they're hyperinflated. They have low diffusion capacity across for carbon monoxide, and they have things like more dyspnea, decreased exercise capacity. In the blue bloaters, what you have is higher body mass index, things like cardiac compromise, OSA and COPD overlap, more chronic bronchitis. I would say that before the advent of CT imaging and spirometry, you actually had diagnoses and interventions that were more targeted towards the emphysema or the pink puffers versus the blue bloaters. But now that we have spirometry and CT imaging, we've kind of lumped COPD all into one category. So if you don't get if you fail LABA-LAMA, you get up titrated to the ICS LABA-LAMA. If that doesn't work, then you go into a higher dose, that sort of thing. This is kind of a detriment, I would say, to COPD because it's so heterogeneous, as we saw before. There's so many chemotactic factors that influence the inflammation and the destruction in the lungs that we don't really have a good way of subcategorizing things within COPD. And that's kind of what we're going with, what we're doing moving forward in the GOLD report. We're trying to come up with these idiotypes. So proposed taxonomy for how COPD and how it transpires. So under that, you have things like genetically determined COPD, COPD due to abnormal lung during development. You have things like cigarette smoking. You have things like biomass and pollution exposure. You have things like COPD and asthma overlap, or you have things like COPD due to chronic infections. These help give us a better understanding and etiology for how COPD came to be in an individual and in a patient. And if we go down the rabbit hole of more research on these things, then they can potentially give us more therapies in order to contribute to COPD and to get our COPD patients under better control. I will say that these idiotypes are mostly used in the research setting. So they haven't really made their way into our clinical practice quite just yet, but they're important to note moving forward because I think that the heterogeneity of COPD is just going to get more and more complex moving forward. How is COPD diagnosed? So we get a pre and post bronchodilator spirometry. This is going to be related to your ratio, your FEV1 to FVC ratio. You measure pre-bronchodilator response and you get your ratio there. If it's above 0.7, this patient does not have COPD. If you have a ratio that's below 0.7, you can measure the post-bronchodilator response. get the ratio, and then see where they fall into this bucket. If they're above the FEV1, FVC ratio, they do have a post-bronchodilator effect. Maybe they have something like COPD and asthma overlap that you want to check. But regardless, this needs follow-up with repeat assessment. Maybe repeat imaging, maybe a CBC, maybe a repeat spirometry somewhere down the line. With a ratio less than 0.7, then you have COPD confirmed. After that, you can go on to grade the severity of airflow obstruction in COPD. And COPD grading is done by the ratio here. So FEV1 greater than 80% predicted is going to be your gold 1s. If it's gold 2, it's going to be your moderate, which falls between 50 and 80%, which is where our patient fell. At gold 3, you actually have severe, so your FEV1 falls between the 30 and 50% mark, and then gold 4 is very, very severe. So this is anybody with an FEV1 30% of what's predicted. One of the cool things I think about the GOLD report is that in 2019, we actually started seeing more emphasis on natural lung aging. And so they place more emphasis on age-related decline of lung function. Some decline in the ratio is normal. So here we can see the supernormal effects of aging. This actually demonstrates healthy lung aging. So over the course of time, from 20 to 30, 30 is about where you peak and then start seeing natural decline in your lung function. This exhibits healthy aging. They created a small little buffer for non-healthy aging, or normal / pseudo-normal aging, which is still above the 80% mark, I want to note. And then anything below that is going to be related to COPD, even at ages such as 80 and 90. So below normal is going to be exhibited here, and then you had accelerated decline or premature death in these areas right here. It's one of the things about aging, though, is that it's linked as a risk factor for COPD because there's physiologic decline in lung function with age, but we don't know if aging leads to COPD or if age just reflects the cumulative damage to the lung parenchyma over time. Regardless, like I said, supernormal exhibits healthy aging, and this can actually lead to further diagnostics and interventions that we can act upon. For example, telomere. Does telomere influence, and can we influence telomere of COPD over time to kind of reduce the number of exacerbations and reduce declining lung function? So we've kind of gone over COPD, what it is. How do we assess it in clinic? These are the assessments. These are the categories that we saw on the assessment scales. So we have dyspnea, the dyspnea scale, and we go from 0 here all the way up to 4. So 0, I only get breathless with strenuous exercise. Grade 4, I am too breathless to leave the house, or I am breathless when dressing or undressing. So our patient fell on the category 4, grade 4. So she's pretty uncontrolled right now. There is only a weak association between the severity of airflow and the symptoms experienced by the patient, which is kind of unique. So patients can feel like they're less in control than they actually are, than what their spirometry will lead you to believe. And then formal assessments using validated questionnaires are still required. So this is a pretty nice, easy, cheap, dirty way of kind of assessing whether or not your patient's under control, but it's not a very in-depth way of assessing them. But this is one of the first questionnaires that was developed, and it still has its utility in assessing our patients in clinic. This is a more comprehensive questionnaire. This is the COPD assessment test, or the CAT test. This is an 8-item questionnaire. It assesses the health of patients with COPD. It was developed to be applicable worldwide, and the score ranges from 0 to 40. With 40 being very, very severe. It's widely validated questionnaire, has been used extensively throughout research, and scores typically above 10 are rarely seen in very healthy individuals. I do want to note that this is a assessment that goes up to 40, which is pretty extensive, but if we compare that to the ACT test, which is one of the things I think I hate about physicians, I think we want to try to stay very relevant throughout the AI boom, is that they actually have widely different numbering systems. So here we actually see a 5 to 25 assessment for asthma, and the higher numbers are actually good, whereas for COPD, higher numbers are bad. So if you see these in your pulmonologist offices, just make sure that you know which one's related to which. ACT 25, good. COPD 40, bad. So let's go back to our case presentation. Miss Emily Fazima. We were able to kind of assess her COPD. Her CAT score is 28, so pretty uncontrolled. Her dyspnea scale is 4, so she does not think that her symptoms are very well controlled. So what can we do about it moving forward? We can do some follow-up questions for this one. This is going to be, we can update some of her tests. We can update her ratio, which was last done in her 2022, so we can update her spirometry. And we see that she was gold 2 during her last assessment. Based on a patient's dyspnea scale, her symptoms are not controlled. She's too breathless to leave the house when dressing or undressing. And her CAT score is 28. So kind of we know that we've given a number to her COPD. But the goals for treatment for COPD is basically this. We need to relieve her symptoms, improve her exercise tolerance, and improve her health status. That's one of the symptom managements that we can do. And we want to prevent disease progression, we want to prevent and treat exacerbations, and we want to reduce her mortality. This is going to reduce her risk for COPD decline over the next years. We can get some additional testing here. So what other tests should we consider in our patient at this point? We can update her spirometry. We can consider getting a chest CT, and we can obtain a CBC. These are really, really important and have been emphasized more so in the last few GOLD reports. So just kind of a general question to everybody. Is a CT scan necessary for the diagnosis of COPD exacerbations? No. I see some heads shaking no. It's not. You do not need a CT for the diagnosis of COPD exacerbation. Do you need it for the diagnosis of COPD? So COPD versus COPD exacerbation. You don't, but it's becoming emphasized more and more in the more recent GOLD reports. So why is it being emphasized more and more? It's because while spirometry can tell us that you do have a disease, it doesn't actually tell you where the disease is. So here, we actually have a good anatomy of a patient's lungs. So here we have lungs at the top, the apices. We have middle to upper lobes over here, and we have lower lobes here. This represents good, healthy tissue right here. Good, healthy tissue. Here we still see some good, healthy tissue, some areas of bullae, so some areas of emphysema. And then here we actually have major lung loss. This is right here reflects diseased lung or COPD lung. This represents healthy lung right here. So we can see here actually that most of the disease burden is towards the top or towards the apices of the lung. And this is really, really important moving forward. This helps us categorize where it is within their anatomy. So many of our COPD patients already qualify for annual low-dose CT screenings based on their smoking history. And what the GOLD report is actually stating is that we should leverage this into getting some baseline imaging of the anatomy of the lungs, because this can influence how we treat our patients moving forward. This can lead to things like endobronchial valves. This can lead to things like lung volume reduction surgery, and it's being emphasized more and more so moving forward. So if you have a patient that comes into the hospital and they have this history of COPD exacerbations and they haven't had a chest CT done in the last 5 years, consider getting an update on it. Consider getting a new chest CT, because you might be missing something, or you might be missing a way to intervene on this patient's COPD. I just think this is kind of cool. These are endobronchial valves. This is one of the ways that we can intervene on some of the diseased lung. So the way endobronchial lungs or valves are done is that these one-way valves are actually placed bronchoscopically. So you find you find the area that's diseased. You target the segment or lobe that's hyperinflated or emphysematous that we saw on the previous slide. During inhalation, what happens is that the valve closes. It prevents air entry. So during exhalation, the valve opens. It allows trapped air to escape, and it leads to lobar deflation. So you're basically causing atelectasis in the diseased lung. This reduces hyperinflation and it improves diaphragmatic mechanics. This is important because that diseased lung is not participating in any kind of gas exchange. So it's not actually helping the patient, it's just hurting them. And this is one of the cool ways that you could kind of intervene on if you see diseased lung in one part but not in the other. Some of the implications or some of the indications, I should say, for this is an FEV1 of less than 45%, some limited collateral ventilation, and like I said, this helps patients, it improves their exercise capacity, it improves their quality of life, and improves their FEV1. Some of the other things that you can consider is things like CBC testing and eosinophils. So this is becoming more and more of a subtype of COPD is what we're seeing. CBC gives you one of the most actionable biomarkers in COPD. The Goal 2025 report highlights eosinophils as a predictor of corticosteroids and biologic responsiveness. I want to highlight that again because that's really, really cool. Gold COPD highlights eosinophils as a predictor of corticosteroid and biologic responsiveness. So for the residents, this is a key teaching point because before escalating inhaler therapy from things like LAMA-LABA to ICS, we want to see if the eosinophils are greater than 300. Here we have a good breakdown of how to think about this. So any CBC with an absolute eosinophil count of less than 100, you see low likelihood for any kind of ICS benefit. You can actually continue dual bronchodilator therapy and consider some other kind of therapy. For eosinophil count between 100 to 300, you actually have intermediate ICS response. So you can consider triple therapy if you have more than 2 exacerbations per year. And then greater than 300 cells, you actually have a strong ICS and biologic response. So you can use triple therapy or dupilumab if chronic bronchitis phenotype persists. This is very, very different than what it was before. Like I said, before we kind of had one standardized way of treating COPD. It was LAMA-LABA, and then if you don't pass that, then you go on to ICS LAMA-LABA, and then if you don't pass that, you go on to high-dose ICS, which carries its own risks and rewards along with it, because that puts you at things like increased risk for pneumonias and things like that. So this is a much more streamlined way of trying to categorize our COPD and introduces a new etiotype into our COPD thinking. The exact role of blood eosinophils in the pathophysiology of COPD, it's not exactly clear. So it seems to increase the effectiveness, it does seem to increase the effectiveness of corticosteroids. And there's some pathophysiology that we think is going on here. Things like IL-5, things like IL-4, IL-9, IL-13 that are playing a role. And I think we're gonna see this as targets for new biologics moving forward, and ways in which that we can intervene on COPD. This has been, eosinophilic COPD is now considered its own distinct disease, which is kind of cool. So we've updated our testing. We've gotten updated spirometry where we see her FEV1 has been reduced from 64% to 49%. We see her ratio has been reduced from 66% to 48%. We see that her diffusion capacity is kind of hovering around the same, 47, but it has been reduced. We've gotten some CT imaging on our patient, which does reflect some disease more so towards the apices of the lung. And we've gotten a CBC, and this does show an absolute eosinophil count that's greater than 300 cells. So we've been able now to categorize this patient's COPD a little bit better. And we can introduce things that can help with her symptoms, and it can help with her mortality moving forward. These are some of the updates for ICS therapy. So factors to consider when initiating ICS is that with patients who have there are multiple reasons for us to start ICS therapy. Some of those include history of hospitalizations for exacerbations of COPD, greater than 2 moderate exacerbations of COPD per year, blood eosinophil count greater than 300, or history of concomitant asthma. This is also still that asthma COPD etiotype that we were talking about before. Some things where it's kind of in the yellow zone include 1 moderate exacerbation of COPD per year, blood eosinophils between 100 to 300 cells, and then anything that's against escalating to ICS therapy include things like repeat pneumonia events. This is a risk factor actually for using ICS therapy. Blood eosinophils less than 100, they're probably not going to have a good response to any kind of ICS. And then a history of any kind of mycobacterial infection. Again, ICS therapy increases the risk for pneumonias and infections in the lung. So we kind of want to avoid initiating this. And then just to add on to the initiation of ICS therapy, the initiation of ICS therapy actually reflects a good response to biologics. So this reflects a good response to dupilumab. And something else that within our arsenal that we can use against COPD. Here we have triple therapy and dupilumab. So you don't have, it's not just one or the other, which was kind of something that, a question that I had. Does high eosinophil count constitute, are patients with high eosinophil counts going to have a response to triple therapy and dupilumab, or is it an either or sort of thing? And what we see is that it's actually, you can use both. So here's a nice little flow chart as to like when we can use LAMA-LABAs. We start out with LAMA or LABA. We can escalate to dual therapy, LABAs and LAMAs. And then if the eosinophil count is greater than 300, we can escalate to triple therapy. Now, moving forward, if they're still uncontrolled, we can add dupilumab as for chronic bronchitis and chronic exacerbations. If they're below 100, we actually have another way to treat these patients. So you can either give them things like azithromycin, which is preferential for former smokers, or you can consider something like roflumilast, which is good for things like chronic bronchitis. Just a kind of a note on how dupilumab works. It targets the IL-4 and IL-3 pathway. There have been some recent trials, the Boreas 2023 trial and the Notice 2024 trial. This enrolled patients already on triple therapy, which is how we know that dupilumab helps. And the biologics provided additional reduction in exacerbations and improved lung function on top of that baseline regimen. So we know that using these things in conjunction actually helps our patient. Evidence supports the use of these add-ons, and then what you want to start thinking about is roflumilast and things like bronchitis, people with chronic bronchitis, and azithromycin for former smokers. I do want to make a quick note here about some of the contraindications to both roflumilast and azithromycin. So for roflumilast, if you have somebody who's underweight, has an FEV1 less than 50, or who are still requiring triple therapy on escalation, you don't want to use roflumilast. Contraindications for azithromycin include frequent exacerbators who are still smoking, and because this is really not going to help those patients. They still have the risk factor for smoking, and it's likely not going to add to kind of their exacerbations or reduction in exacerbations. Don't combine azithromycin with any other kind of QT prolonging agents. And you always want to monitor these patients, usually every 3 to 6 months, for any kind of things like GI side effects for roflumilast and any kind of EKG changes and or hearing changes while they're on azithromycin. This is another one that has been added to the Gold 2025 report. This is a brand new inhaler. So this is a PDE3 and PDE4 inhibitor that's already being used in COPD and by pulmonologists. This is called ensifentrine. It's a novel, first-in-its-class inhaled dual inhibitor of PDE3 and PDE4. It's anti-inflammatory and a bronchodilator effect. The PDE3 inhibition it modulates the cyclic GMP levels, and it causes smooth muscle relaxation. And it's been widely studied already in phase 3 trials and is already out for prescription for some of these patients. Some of the studies that have come out for this are reduction in exacerbation rates. The problem with this, though, is that we still need to study it more. So we don't actually know if some of these inhalers add to our triple therapy or if they can be used in isolation by themselves. But it just provides us with another tool for helping our COPD patients. So going back to our case presentation, let's revisit it. We've been able to update her spirometry from 2022. We have new numbers to associate with her. We've been able to say, hey, you're on triple therapy, but you're not on the maximum dose quite just yet. She still uses some PRN SABAs and SAMAs, and we've been able to assess her COPD. And this is kind of just a summary. So we've, again, evaluated our patient, assessed the patient's validated questionnaires, obtained labs and imaging. We've isolated patient's COPD to apices based on imaging. We've increased patient's triple therapy at this point, and we're starting her on ensifentrine, which is this novel bronchodilator. We can consider dupilumab if she's still not controlled, but let's take things slow first since we're adding so many things to her regimen. Some other things that you can add to this patient's regimen is, of course, smoking. She still smokes half a pack per day, and one of the cornerstones of COPD disease management is actually stopping smoking. So smoking, tobacco dependence is a chronic condition, warrants repeated treatment, repeated follow-up. Clinicians and healthcare delivery systems need to operate together on this. So both our inpatient and our outpatient colleagues need to work on getting patients off of smoking, as this is a chronic disease and can impact patients' lung function significantly. Some other non-pharmacologic interventions is things like pulmonary rehab. So pulmonary rehab is arguably one of the highest value therapies in COPD. It's not optional or adjunctive at this point. It's being considered more so to start patients once they have their initial COPD diagnosis within the first 4 weeks of diagnosis. So it reemphasizes that we should refer all symptomatic patients, regardless of severity, regardless of their function, and especially after any kind of hospitalization, that they need to be sent out for pulmonary rehab referrals. What is part of it? There's a lot that actually goes into pulmonary rehab. It includes things like endurance and resistance training with 2 to 3 sessions, up to 8 to 12 for up to 8 to 12 weeks. This improves things like dyspnea, VO2 max. It improves our education. So disease understanding, inhaler technique, pacing, energy conservation, all of these things are things that help with our patients. The thing that I've noticed helps the most is probably things like inhaler technique, which is important to emphasize in all of our clinic follow-ups. It provides behavioral support. It leads to smoking cessation. It allows patients to ask questions about their nutrition. It allows patients to talk about their anxiety, depression management, which if you're a patient with COPD and you're feeling short of breath every day, that can contribute and turn into this ever-ending cycle of dyspnea and anxiety, dyspnea and anxiety. Gives us things like self-management training, which includes action plans for any kind of exacerbations and early warning signs. And it also allows for maintenance and tele-rehab. So things for home-based or virtual programs are now supported by the Goal 2825 for long-term adherence. Other things that we can talk to our patient about while she's here in our office is things like vaccinations. So one of the things that I found while going more into this is that there is only one vaccine that actually has a level A support for prevention of COPD exacerbations, and that's RSV. Now, the reason for this is not because the others don't work, such as influenza vaccine, COVID-19 vaccine. All of these things do help in controlling COPD exacerbations, but the thing is that RSV is the only one that's been studied specifically in the COPD population. And so while we know that influenza vaccines, COVID-19 vaccines, Tdap vaccines all help patient symptoms, they haven't been studied. They've been studied more so in the general public and not necessarily just in COPD patients. And then this is our COPD follow-up checklist, because this can be a lot for patients to follow up on. So where this gives us some kind of baseline on their symptoms, it allows us to categorize their symptoms here in the office. It allows any kind of recent change in symptoms and allows us to kind of categorize them, whether there's a change in sputum color, there's more dyspnea, more cough, more sputum volume. It allows us to know which kind of inhalers these patients are on. And it allows us to kind of document if they've had any recent COVID-19s. They can have a written action plan if they do feel like they're exacerbating more frequently. And then we can talk about any kind of recent admissions or emergency visits. This COPD questionnaire also has a self-management for any kind of healthy behaviors. This includes utilizing a smoke-free environment, medication adherence, prevention management of exacerbations, that sort of thing. And so we've kind of now addressed everything that's going on here. We note that this patient is here in clinic in October. We've updated her on being able to go through vaccines. We've counseled her on tobacco use and the importance of quitting smoking. We've updated her moderate to severe COPD. She is now officially severe COPD. We are going to give her a referral for pulmonary rehab, which will hopefully improve some of her symptoms, give her some of those added benefits. Again, updated the spirometry. We've also been able to categorize the anatomy of her COPD a little bit better and know that these are more towards the apices. We can start considering giving this patient a referral to any kind of interventional pulmonologist or any kind of cardiac surgeon for help with lung reduction. And we've updated some of her medications. We've added a new PDE3 and PDE4 inhaler to her regimen, as well as gone up on her triple therapy from 100 micrograms to 200. And we've successfully been able to categorize all her symptoms. So where does that leave us with some of the Goal 2025 updates? The last one that I want to kind of highlight here is this new dedicated section to climate change. So climate change is becoming increasingly more recognized throughout the world, and its effects on COPD have been increasingly more recognized. So what does that include? That includes things like extreme heat, wildfires, pollen, extreme weather events, viruses. All of these things contribute to the respiratory health outcomes and can contribute to asthma exacerbations, COPD exacerbations, increased allergy, disease morbidity, reduced morbidity and mortality from viral illnesses. This is the first time that this has gotten its own dedicated section within the Goal 2025 report, which is kind of a big deal, showing that there's an interplay between how our world is changing and actually the pathologies that we find in the hospital. I'm curious to see how they expand on this, if there are any interventions that can be expanded upon going forward. There's already been some consultation or some guidance on consulting our patients to make sure that they avoid some of these triggers that could lead to COPD exacerbations. And so targeting some of these therapies will be kind of interesting moving forward. So that being said, let's go through some questions. At what blood eosinophil count does the Goal 2025 recommend strongly considering triple therapy or biologic? Anybody?
C.
C, very good. Which of the following therapies is newly included in the 2025 GOLD recommendations?
B as in boy.
B, very good. Which vaccine received a grade A recommendation in GOLD 2025 for COPD prevention? C, awesome. You guys are killing it. And then, oops, whoops. According to GOLD COPD, which of the following criteria confirms the diagnosis of COPD? Just say it. Here are my references. And I want to thank my mentors for helping me with the presentation and throughout my career. This is going to be Dr. Kumar, Dr. Patel, Dr. Kutab. I also want to thank some of the other attendings who have heavily mentored me throughout my years here. This includes Dr. Bangu, Dr. Chishomi, Dr. Tandra, Dr. Z, Dr. Sulov. And then I also want to send a shout out to some of my friends in residency, all of whom I could not have gotten here without you guys, Dr. Kalra, Dr. Lowe, and Dr. Sanders. Thank you guys so much.
I think this was excellent. Very well done. I think one of the things I was curious about as you were reviewing the literature, did you come across literature that showed if patients quit smoking, how much of lung function reversal do they get?
Can you say the last part again? How much lung function, what?
How much reversal in lung function do they get after they quit smoking?
Yeah, so some of the studies that I saw is that there is actually no reversal in lung function, and that's probably one of the golden bullets, I think, for COPD. That all of these interventions that we have do not reverse lung function. Whether it's triple therapy, whether it's smoking cessation, whether it's intervention for our counseling on patients and their environment. None of these things reverse lung damage. So what we can only do is we can slow the decay or slow the disease process itself. And so that's kind of why I liked the one slide about aging. It shows that no matter what, we're going to have some kind of decline in lung function throughout our years. Now, if you have exposures to irritants and smoking, you can accelerate that lung dysfunction. But there's no therapies yet that actually reverses lung function. Yeah, so shameless plug for that. That's one of the reasons why I liked I chose this as a topic. So Dr. Patel, myself, Dr. Jeff over there in the background, Hosni, and Dr. Sun, we were all able to kind of come together and we were able to kind of exhibit where patients that have COPD exacerbations, and we were able to identify a specific temperature in which they had increased mortality at one end and increased hospitalizations at the other end. Forgetting which one is on which side right now, but that's fine.
Yeah, we should have more discussion in general than just one person. But Michael, good job with your presentation. That flowed very smoothly. You can tell that you have mastered this topic, and I like how you went through the lens of a case and very clinically relevant. I usually don't take a lot of pictures of the slides, but this is definitely relevant as COPD exacerbations as well as just declining progressive COPD is a very common reason for hospitalization. And then I appreciated how you, with the GOLD criteria, how you explained the methodology and how maybe it is a better guideline, more evidence-based guideline than maybe other society guidelines, since they update it so frequently. And incorporated the most recent practice training studies into it. Then my one question here was related to this figure, actually, because I always want to believe that if we live well, that age will have a minimal effect on progression of disease. And I wonder if, like, those climate change factors, exposure to pollution over time is what explains this. But do you have any thoughts on what best explains this age-related decline?
Yeah, I think that's kind of one of the something that I hope we're able to expand on future in the in research. So I think one of the things that I had talked about for age-related decline is that we don't know if age is contributing to COPD, or if this is just something we see as you age. Right? So we don't know if the lung function is naturally just naturally declines, or if it's just something that we see and they're kind of correlated. This is going to be tackled more so probably by things like mice models, rat models, and the biggest driving factor, or the biggest thing that they were able to outline in the Gold Report is actually the study of telomeres. So telomeres is, if for those who don't know, is actually DNA when it replicates, the DNA gets shorter and shorter and shorter every time it replicates. So as you age and you need to replicate your DNA for cell replication, then your DNA gets actually shorter and shorter every time. Telomeres, what that is that's kind of like junk DNA at the ends of your chromosomes. And so our bodies have evolved in such a way in that the telomeres start getting clipped more and more, but those telomeres don't actually contribute to who you are as a person. Studying that more actually is probably going to lead us into to answer this question, which is, can you completely prevent, or can you completely escape this natural decline that you see in lung function? And that I don't have an answer for.
Thanks, Michael. That was a great presentation. My question is around the endobronchial valve that you mentioned and the comparison of that to lung volume reduction surgically. Have you seen was it compared, or is there any data behind it? And are they moving towards endobronchial valve now?
That's a great question. I actually don't have an answer for that. So they kind of lumped all of these surgeries as one category. I think this is probably a little bit harder to study because you're only going to get these interventions at very heavily researched institutions. So for example, like we don't do endobronchial valves here. We do lung reduction surgeries. And so it's probably going to be dependent on the institution that you're at where they're able to study this. But direct comparison of one versus the other, I don't have or at least I didn't see a good study on that. But that's a great question.
Thank you.
Yeah.
All right, thank you, Dr. Vidal.